Good evening, everyone. My name is Debbie Hill-Bissell. It is Thursday, September 29th, and tonight we're going to be doing case list review or case list defense for the next hour and a half. So I don't even know that I need to go over this, but I say this every time and I still do it. So let's just look briefly. There's a little orange arrow that can open and close your panel if you need to. And then it looks like the vast majority of you are using mic and speaker, so you don't have to do a darn thing. But if for some reason you're calling in on a telephone, if you click under audio mode, use telephone, you will get a phone number, an access code, and a PIN. The most important thing is how you volunteer. And so what you'll just do is you'll raise your hand. I'll unmute you on my end, and then you just need to make sure you're unmuted on your end. So you'll have underneath your orange arrow, you'll just make sure that you're unmuted on your microphone. All right, so you know how, all the faculty do their webinars a little bit differently, and I like to always start out with just a quick little couple minutes of a clinical pearl. So today I thought what I would do is talk about hepatitis C in pregnancy. And the Society for Maternal Fetal Medicine actually has issued a position statement that addresses what they recommend for hepatitis C in pregnancy. So I've got about 4 or 5 slides. Let me just briefly go through them. It'll just be a good review. So there's about a 5% risk of vertical transmission of hepatitis C. So if you have a hepatitis C infected mom in pregnancy, this transmission can occur both in utero and during the peripartum time period. The risks that we look at, partly we look at the mother and how does pregnancy impact her health and how does it impact the viral load and her liver functions, etc. But with regards to the fetus, we know that there's increased risk of fetal growth restriction, low birth weight, and increased risk of NICU admissions with ventilation required. So who should we screen? Most of us now are just doing universal screening for hepatitis C. But in the MFM Society for MFM, in this publication, it says screen all women at increased risk for hepatitis C with anti-hepatitis C antibody at their first prenatal visit. And if that initial screen is negative, you should repeat that screen later in the pregnancy for women who have new or persistent risk factors such as injected or intranasal illicit drugs, they have a history of incarceration, they have unexplained liver disease. And in this publication, there's a whole box of different things that increase the risk. But most of us are going to screen at the first prenatal visit. And then I just want you to be aware, if you do have patients who are at risk, you would still repeat that screen later in their pregnancy. Of course, this makes sense for any pregnant woman. They should abstain from alcohol, but anyone with hepatitis C should abstain from alcohol because of the impact of alcohol on the liver, and they already have problems with liver disease. The direct-acting antiviral regimens we know they work, right? We know they can clear the virus, or at least we can get undetectable levels. However, we do not have data in pregnant women, which is unfortunate. So the direct-acting antiviral regimen should only be used in the setting of clinical trials, or they need to be deferred to the postpartum period as they're not approved in pregnancy. And of course, what we're supposed to do, well, I'll get to that in a minute. All right, if invasive prenatal testing is required, we have very limited data about does it increase the risk of vertical transmission. So the data we have is very reassuring, but at this point in time, amniocentesis is still preferred over CVS if you're going to do invasive prenatal testing. You should not do a cesarean section solely for the indication of a mother infected with hep C. So even though there's the 5% risk of transmission, you don't do a C-section just for that. You should avoid internal fetal monitoring, prolonged rupture of membranes, and an episiotomy, if at all possible. You should not discourage breastfeeding. It is okay with a hep C mom. And then if you do have a mother who is test positive for hepatitis C, we've already screened her for hep B as part of the prenatal evaluation. But if she's not been immunized against hep A and hep B, it should be done, and those vaccines are safe in pregnancy. So let's take a look at the testing for a minute. So let's say, as part of the screen, what are you supposed to do? You get the hep C antibody test. If it's positive, then what you're supposed to do is test for hepatitis C RNA. If the RNA comes back negative, so you got the positive antibody and the RNA is negative, they said there's two things. You should either consider doing a different type of antibody test to see if this is just a false positive, or it may actually, like if the second one also came back positive, she would be one of those few rare people who actually cleared hep C from her body, and this would be a cleared true infection. Does that make sense? All right, that's not going to happen very often. If the hepatitis C, if the hep C RNA is positive, so now you got the hep C antibodies positive and the hep C RNA is positive, then you're going to get a quantitative level, which is going to be the viral load, and you need to check the hep C genotype because there's 6 different genotypes, and the genotype does determine which therapy is going to be most efficacious. You're also going to get baseline labs to determine the extent of liver disease. You're going to check a bilirubin, ALT, AST, albumin, platelet count, and a PT. However, I would have thought serial surveillance would be recommended, and at this point in time, they don't recommend it. They just say you get that as part of your initial workup. If you test negative for the hepatitis C antibodies, but you know this patient has possibly been exposed in the prior 6 months, they actually say you can test for the hepatitis C RNA because she truly may just not have seroconverted yet and made antibodies. So this may be getting a little more complicated than what they would ask, but it's something that you should be aware of. All right, so if the hepatitis C is positive, if they're hepatitis C positive, you need to refer these patients, even while they're pregnant, to a hepatologist or an infectious disease specialist. These people will treat the patient once she's postpartum. They can do their 3 months of therapy and they should be able to eradicate it. We talked about the 6 different genotypes and how it affects the choice of treatment. Now, here's what's kind of interesting. So if there's a 5% vertical transmission, how do we figure out if the baby's infected? Now, the anti-hep C antibodies do cross the placenta. So the presence of those antibodies in the neonate serum does not indicate infection. So what they say, the way we can tell if an infant is infected with hep C is they have to have a positive hep C viral RNA on at least 2 occasions when they're greater than or equal to 1 month, or if they are anti-hep C antibody positive at 24 months of age. So that is your little hep C lecture for today, the mini lecture. All right, so we've got about 40 people online so far. So let me do what I always do. If you have not been called on at all during the month of September and you would like to be called on, please raise your hand. So first of all, I'm going to lower everybody's hand, and now I'm going to ask that again. If you've not been called on at all during the month of September and would like to be called on, please raise your hand. All right. Oh, I know what I got to do. I got to get the case list up. Hang on. Let me pull up the case list. All right, good. All right, let's get Geeta. Hey, Geeta, how are you doing?
I'm doing well.
Good. So are you a generalist or are you a subspecialist?
Generalist.
Okay, and do you have a particular, oh, the other thing too, you guys, if you have a particular case or case list that you would like to discuss, please let me know. And how come, are you under a different last, oh no, here you are.
Yep.
I didn't see it at first. All right, do you have a particular case or case list you would like to start with?
I think anything is fine.
All right, let's just start at the top.
Okay.
So you're pretty busy. You've got 15 pages worth of GYN stuff.
Yeah.
Let's see here. I just want to look at this. Well, yeah, I'm going to look at the patient 13 just because it was interesting. So you had a
Okay.
43-year-old who presented with abnormal bleeding. She had dysmenorrhea. She's obese. You did a ultrasound that showed 2 submucosal myomas. Now, prior to taking her for treatment, did you do an office endometrial biopsy?
I did not. The reason for that is because the abnormal uterine bleeding was thought to be due to the fibroids, and the thought was to resolve the bleeding with removal of those submucosal fibroids.
Okay, in general though, when somebody presents with abnormal uterine bleeding, I
Mhm.
know if I asked you your well, let me just ask you, what's your differential diagnosis?
Sure. So there's structural and non-structural sources for abnormal uterine bleeding. So for structural, we think of polyps. We can think of adenomyosis in the wall of the uterus, fibroids, and um, we can think of malignancy. We can also think of non-structural sources, so like rarely, but coagulopathy and anovulatory bleeding, iatrogenic bleeding with use of anticoagulation, endocrinologic disorders such as thyroid function, and there can be other things that we just haven't identified yet as a source of bleeding.
Okay, so in somebody who's 43 and obese, tell me how you're going to evaluate her abnormal bleeding.
So first I would do a thorough history and also a physical exam. So I'd want to know the duration of her abnormal bleeding, if it's new or if it's been persistent for quite some time, how she describes her bleeding, so how many days her menstrual cycle lasts, the regularity, etc. In somebody who's obese and describing abnormal uterine bleeding, I'd expect the possibility of irregular cycles, which would raise the possibility of anovulatory cycles, which would increase her risk of malignancy or precancerous lesions of the uterine lining.
Okay, so with the AUB, so you're going to do the ultrasound as you did. You saw the submucous myomas. Do you get any lab work done?
So for somebody who's had irregular heavy bleeding, I would get a CBC. And then if it is oligomenorrhea, then I would also do a workup for potentially PCOS. So I'd want to address if there's any hyperandrogenicity. I would also want to look at her lipids and glucose and that sort of thing. I would also consider doing a thyroid level and prolactin level as well.
Okay, so let's, in the prolactin level, I know you're going to do a CBC and a TSH. That makes sense to me. With a elevated prolactin, what does that usually do to menses?
It stops the menses. So if she's had like a prolonged period without a period, that would raise that concern.
Okay, all right. So anyway, if you were going to try medical management first,
Mhm.
would you have done any further evaluation on her before starting medical management?
If I didn't see any structural lesions, I would do an endometrial biopsy to rule out a malignancy before starting medication.
Okay, so in this case, you're like, you've got this submucosal myomas. I'm going to take you to the OR and attempt removal of those, and
Mhm.
I'm going to get endometrial sampling at the same time.
Correct.
Correct. Okay, all right. So with the hysteroscopy, did you see submucosal myomas?
I did not in this patient.
Okay, so so you did the hysteroscopy, did a DNC. Did actually the endometrium look pretty normal, Gita? I mean, like no
It did. Yeah.
weird. Interesting. Okay, but anyway, the good news was you had already planned on inserting a levonorgestrel IUD,
Yes.
right?
That was
Okay.
discussed with her ahead of time, given both her dysmenorrhea and the abnormal uterine bleeding that may have been due to other factors than her fibroids.
Okay. And so she got back a benign endometrium. She's got her levonorgestrel IUD in place. And really what was just interesting was what the ultrasound showed and what you saw
Correct.
was inconsistent. All right. So I guess the only other question would be if she really did have two different submucosal myomas, you were doing the hysteroscopy with the morcellator, and all of a sudden you had a rapid increase in the fluid deficit.
Mhm.
So, and you're worried about a perforation. Tell me how you're going to manage that.
So my first concern with the fluid deficit, like you mentioned, is the concern for a perforation. So initially, I would remove the morcellator, any objects that have the potential to cause damage. I would do an inspection with the hysteroscope still in place to see if I can identify a perforation visually with the hysteroscope. If I do see perforation, I would assess if there are any abdominal contents coming through the perforation. If there are not, then I would stop the hysteroscopy procedure and then observe the patient postoperatively for any concerning symptoms. If I did see any abdominal contents that were coming through the perforation, then I would convert the case to a diagnostic laparoscopy and do a thorough assessment of the intra-abdominal cavity.
So with regards to perforation, does it make a difference to you what instrument you perfed with?
Yes. So if I perfed with like a dilator upon entry, my concern for causing injury to organs is much less versus if I were to have perfed with a morcellator, particularly while it's active, then I would be much more concerned about the possibility of causing injury inside the abdomen.
Yeah, and would you just routinely, even if you didn't see something, I mean, even if you didn't see contents, would you just routinely do a laparoscopy if you were using the morcellator and you perfed?
If I was using the morcellator and it was active, then I would do a diagnostic laparoscopy. If the morcellator was present through the obturator of the hysteroscope and it wasn't active at the time of the perforation, I wouldn't necessarily go straight to a diagnostic laparoscopy.
Okay, good. All right, that's really all I have to ask. And I'm sure you counseled her and you told her, well, the good news is there were no fibroids. So really, in hindsight, you could have just done an office endometrial biopsy and put in a levonorgestrel IUD. But I bet you she was happy to be under anesthesia to have
Yes.
both of those done, because they're not comfortable procedures. That's for sure. All right,
Absolutely.
good. I think you answered it excellently.
Perfect.
And you have good thought process for why you did what you did.
Thank you.
Thanks, Geeta. All right, so let's see who else. Hey, Maya, I'm going to pull up your case list.
Hello, it's probably, I think, under Rolf,
Under what, Ralph?
Rolfe.
Okay, there we go. I thought sometimes. So is Dominique is your married name?
Yes.
Hey, I know. I think the guys should just have to change their names, but you know, never mind. Okay, so what are you a generalist?
Yes.
Okay, tell me, do you have a particular case or a case list, or what would you like to do?
We can do something under office.
Okay. All right, and then I'm going to jump toward the end because we always have a tendency to just pick something quickly, and let me just see what I can find here. All right, let's look at patient 37. So you have a 53-year-old G1P0 who presented with vasomotor symptoms. You did a physical exam, definitely noted some atrophic changes. You did a lipid panel on her that you're listed at cholesterol 210, triglycerides 150. Everybody can read that, and everything else was normal. So tell me, let's look at the cholesterol. What's the significance of that cholesterol for you?
So the first thing is the cholesterol is greater than 200, which is abnormal.
Okay, and what about with the breakdown? What about the LDLs, HDLs, etc.?
So the LDL, you don't want that over 100. The HDL, we would want that greater than 50. And the triglycerides are concerning greater than 170, specifically if they have other comorbidities.
Okay, and so anyway, so you counseled her on diet and exercise to try to control her cholesterol. What sort of things would you counsel her about?
So the first thing that I talked to her about was the importance of diet and exercise, not just one or the other, but more specifically with the diet, decreasing her fat intake, being more specifically with if she uses oils, using more of like an olive oil instead of like a vegetable oil. Also, she could take omega-3 she should also increase her diet with omega-3 fats, which are high in like nuts as well as in things like fish. I typically counsel my patients that they could look up specifically like more of a Mediterranean diet. And then I counseled her on exercise, at least 30 minutes of exercise 5 days a week if possible.
Okay, and so then you're going to repeat her lipid panel in 6 months. What if it's the same? How do you determine, do you place people on statins, or how do you determine if somebody should actually be on a statin?
So if her triglycerides are greater than 170, or if they're still 150, and this patient didn't have any like high risk factors such as diabetes or cardiovascular disease, I would not place her on a statin at that point. If she did have triglycerides over 170 and she had cardiovascular disease or diabetes, then we would discuss placing her on a statin.
All right, so she wanted to discuss possible options for vasomotor symptoms. So tell me how you counseled her about her options.
So because she did have, the reason why I did the lipid panel is because I do understand that if I do place her on an estrogen, it can increase her lipids. So I talked to her first about trying possibly more non-hormonal options. I gave her the options, even over the counter. There are particular supplements that have different herbal medicines, such as like black cohosh in them to decrease her vasomotor symptoms. I discussed with her to make sure that she wears like layers her clothing, as well as stays away from hot foods, decreasing alcohol, caffeine. Those particular things could potentially support with her symptoms. And there are other like non-hormonal options, such as an SSRI, specifically paroxetine, that has been shown to support with vasomotor symptoms.
Okay, so which part of the lipid panel can be worsened by hormones?
I believe it is the triglycerides.
You would be right. So, and so if, I mean, because in general, we should see improvement in total cholesterol. We should see improvement in HDL, possibly even a decrease of LDL with any form of estrogen. What form of estrogen increases triglycerides?
I would be guessing here. I wouldn't guess there. I would just say I don't know, but I would say the ethinyl estradiol.
Oh, I'm sorry. Maybe I didn't ask. It's the oral estrogen. So
Oh, okay.
if somebody had elevated triglycerides, you should put them on a transdermal patch because that does not increase their triglycerides.
Okay.
But you did a really nice job of talking to her about the importance of diet, exercise, etc. And as to when to start a statin for primary prevention, Maya, you're right. It's way more complicated. You do not just look at the cholesterol numbers. You can actually calculate the Framingham risk score, and it looks at their I think it's their 10-year cancer risk, cardiovascular risk. It might be a 5-year, it doesn't matter, but it looks at what is their risk now and over a 10-year time span. And you put in like their age, their weight, their systolic blood pressure, their LDLs, their HDLs. And so you put all these different factors in and you hit like calculate, kind of like we do the FRAC score. If their risk is 10% or greater, they recommend a statin. If it's like 7.5% or higher, that's like try diet, exercise, and all that other stuff first. But if they don't improve it, you can consider it. But there actually is a scientific way that you can assess putting somebody on a statin. And it's fine for you to say, I don't prescribe statins, but what I do know is this patient isn't a candidate for statins yet. I'm going to work really hard on helping her to improve her lifestyle, her diet, and incentivize her by repeating her lipids in 6 months. And then with regards to the vasomotor symptoms, you touched on what ACOG wants us to touch on, the lifestyle changes first, dress in layers, keep your ambient temperature cool. And then what you ingest. Alcohol makes hot flashes worse and it disturbs sleep. Caffeine can make it worse. Spicy foods can make it worse. So all of those things are important. And then you're right, you really could put her, if she didn't have any other like contraindications, on hormone therapy, but she would be best served by transdermal versus you could obviously put her on paroxetine or gabapentin or any of those. So good.
Thank you.
All right, and then if you did put her on paroxetine and she had adequate control of her vasomotor symptoms, but the vaginal dryness and atrophy persisted, how would you address that?
So specifically, since it's more localized in the vagina, I tend to I do prescribe vaginal estrogen.
Yeah, and how would you prescribe it?
So there are different options. Specifically, you can do like a vaginal ring, but some insurances don't cover it more specifically in my patient population. So I tend to do just like the vaginal esterase cream, and I tell the patient that they can use the cream, just a very small amount of cream that they can use that daily. And we tend to do like a to 3 week on and a week off to see if that gives some relief.
So you prescribe it how?
So
You have the estrace vaginal cream, and you have her insert it every night for 21 days and then not for a week?
yes, more specifically, if they still have I believe I read that if you have a uterus, you should not continue the vaginal estrase cream greater than 3 weeks at a time.
So in general, so here's the thing, because I have had candidates tell me before that for different medications, be it clobetasol ointment, estrase vaginal cream, etc., the examiner's saying, so tell me exactly how you prescribe it. And so there's really no right or wrong way, but usually with the estrase vaginal cream, you can just have patients insert 1 to 2 grams at bedtime, like 3 times a week, and have them do that for a month or two, and then get their tissues re-estrogenized. And then you can just decrease it maybe to twice a week, and maybe even eventually have them just be on it once a week, just to maintain what you have. So you really don't have to make them go off it, but they really shouldn't be using it every single night indefinitely. Does that make sense?
And it does, so more of a taper
Yeah, yeah.
option.
So yeah, initially it's kind of like the Vagifem. You do it every night for 14 days, and then you go to 3 times a week. With the estrase vaginal cream, you could do the same thing to give it a boost. Do it every night for 14 days, and then taper it off. But most of us will just start like, okay, Monday, Wednesday, Friday, put 1 to 2 grams in intravaginally, and they really will see improvement in symptoms fairly quickly. There's always been a big question: if somebody has a uterus and they're on estrogen vaginal cream, do you need to give a progestin? The answer is no, but you also shouldn't be giving it every night. I mean, it should just be a couple times a week.
Got it. So the Monday, Wednesday, Friday, you can do that for, you said 2 to 3 weeks. You said 2 months, up to 2
Yeah,
months, and
you
then
basically,
taper down.
yeah, because you just want the tissue to get improved. It can take 8 to 12 weeks for the tissue to improve, to actually become well estrogenized. And once it's well estrogenized, your goal is just to maintain that. I have some patients who they just use it the 1st and the 15th of each month, and that actually is enough for them. Do you see what I'm
Got it.
saying? So
Yeah,
you're
that makes
going to
sense.
kind of do it and then try to taper it down to see what will maintain their results.
Okay, thank you.
Okay. Good. Thanks. That was a good one. All right. So I'm looking. So is that it? Those were our only 2 victims who wanted to go tonight, who haven't gone yet. All right. So, oops, whoops. Here's somebody else. Andrea. Hey, Andrea.
Hi, how are you?
I'm good. Let me see if I can find you here.
I don't see my case list.
And you don't
So
have a different name or anything?
no, no,
Dang.
ma'am.
All
I mean,
right.
we can go to the next person. That's okay.
No. And you're a generalist, correct?
Correct.
All right. Well, I'll just make something up and throw at you. How about that?
That's fine. Can I ask you a question before we start?
Yep.
Um, is there any rule in continuing estrase or any form of estrogen cream indefinitely in patients who are postmenopausal who suffer from vaginal atrophy, like maybe once a week for maintenance?
Till they die, they could. And I mean that sincerely, because it's one of the few things that won't improve, because vasomotor symptoms may actually decrease over time, but
Okay.
the estrogen deficient changes of the vulva, when they stop using them, it's just going to go back to being atrophic. So let me ask you, so let's say you had an 87-year-old who came in to see you with, because I was going to go here, but I'm going to I'm going to ask you a different question in a minute, but let's
Okay.
say you had a 76-year-old patient who came in with a history of recurrent UTIs. She's not sexually active. She's been widowed for 5 years. You do an exam. There's no significant pelvic prolapse, but you do see significant vulvovaginal atrophy.
Okay.
Would you give her vaginal estrogen?
Yes, I
Why?
would. Because what we've seen is that the vaginal estrogen cream can improve patients' UTI symptoms, especially in the postmenopausal patient.
Do we know how it lessens UTIs?
I'm not really sure, but if I can take a wild guess, I would assume that the estrogen is revitalizing the tissue, especially the urethral tissue, the vaginal tissue, and that in and of itself will improve her cystitis symptoms or her recurrent UTI symptoms.
Yeah, so a couple of things. The bladder and the urethra actually have like estrogen receptors on them, and so by re-estrogenizing the tissues, one of the things that you're doing is you're making the urethral mucosa thicker and plumper, so it's going to be a little bit better at resisting ascending bacteria to the bladder. But the other thing we're doing is improving the vaginal flora, right? So now we're going to get a more acidic vaginal pH. We're going to have healthier vaginal flora. Lactobacilli can thrive better. They'll get less BV and less UTIs. So for both of those reasons. So yeah, that's why and even look at our patients with pessaries. We will keep them on estrogen cream in order
Correct.
to prevent their erosions, etc. So you really can do it indefinitely.
Correct.
Okay,
Okay.
so now let's keep in the GU frame of mind. Let's say you've got a 52-year-old comes in for her well woman exam, but she also complains to you that she's been experiencing some urinary leakage. Tell me how you're going to evaluate her and what differential diagnosis is going through your head.
So one of the first things that I would do is, history and physical on her, just kind of ask her since when has this been going on? When does it happen? Does she have any nocturia? Does she have frequency? Just kind of get a glimpse or an idea of what type of urinary incontinence she has or how long has this been going on. I'd also ask for some risk factors if she's had a operative vaginal delivery or just a macrosomic baby, if she has a history of pulmonary disease like COPD, if she's obese, if things like that, or she's a smoker. In terms of physical exam, I would do on a pelvic exam, I would just take a look at the perineum. Do I see a prolapse? Do I see just on basic evaluation to see if she has a prolapse. What I also do is that I kind of sit out of the way, but I have the patient cough and see if I can reproduce the leakage of fluid in that sense. And I would also get a transvaginal ultrasound and a UA and a urine culture.
And what would the transvaginal ultrasound help you with?
To be honest, I don't think it would help us much, but it's something that we do a lot in our practice, that anything towards anything with a urinary incontinence, we just do a transvaginal ultrasound just in case. But in terms of management, I don't think it would do much in terms of how I would treat her or how I would further evaluate her.
So here's what you could say with regards to that, Andrea, if you really wanted to. A lot of our patients are obese too, and it is difficult to do a good pelvic exam.
Okay.
I could see doing an ultrasound to rule out some sort of pelvic mass that maybe was not easily detectable. Because obviously, if somebody had a large myomatous uterus, which you hope you'd be able to feel, but in some patients it's difficult. That certainly could be putting pressure or compression on the bladder. You know what I
Okay.
mean? So you could say something like, first of all, you don't even have to say you do it, but if you do say it, you could say it was just to rule out any type of pelvic pathology or masses that could be contributing to her incontinence.
Okay.
Do you see what I'm saying? I could buy that. Okay, so let's say she comes in and it's really more of a urgency type thing. You know, has to go pee all the time, and when she goes, it's not even a large amount, and she gets up a lot at night, and she sometimes pees on herself before she makes it to the bathroom. She really doesn't have much in the way of stress incontinence with cough, sneeze, etc. You did a cough test that was negative. There was no real significant hypermobility of the urethra, and her UA and urine culture was negative, because that could certainly make her get, urgency and frequency symptoms, a UTI.
Mhm.
How do you assess post-void residuals on everyone, or only if there's a certain degree of prolapse?
I would get a post-void residual when I don't see the usual, stress urinary incontinence. If I would see a patient like this, I would definitely get a post-void residual, but I
Okay,
wouldn't do them on all my patients complaining of incontinence.
what would be an abnormal post-void residual?
An abnormal post-void residual would be anywhere above 100 to 120 cc's of urine, I believe.
Okay. All right. Usually they say, and that's fine, but usually because it really should be about less than 50, but really we say anything greater than 150 is abnormal. So that's just kind of a generous cutoff. With regards to a post-void residual, now hang on, I was going someplace really good. Oh, I know what I was going to ask you. How many cc's of urine does a normal bladder hold?
I want to say between 250 to 300 cc's of urine, but I'm not sure. I'd have to look that up.
Yeah, it's maybe a little bit more than that. It's about 350 cc's right in there. Like a can of Coca-Cola is 322 milliliters. So basically every time we pee, we should be able to fill up a can of Coca-Cola. So just saying, just saying. Okay,
That's a
but
good
anyway,
reference point.
yeah. So, I mean, because oftentimes with overactive bladder, patients void frequently and they void small amounts. And that's part of it, because they're not voiding because their bladder's full. They're voiding because they're getting an unprovoked bladder muscle spasm. So now you've diagnosed her with overactive bladder and urge incontinence. So tell me how you're going to treat her.
So in my practice, usually we send these patients to urology for further evaluation and for management. But I believe that if I would be the one who is treating her, you can try certain medications in order to improve her incontinence symptoms.
What about lifestyle changes? Are there anything, like maybe she can't get in to see the urologist for 3 months? And so are there anything that you could recommend her to do while she's waiting?
She can do timed voiding, like she can have, that she goes every 2 hours to go urinate, positive, I believe it's positive biofeedback she can also do, just kind of training herself and her body to go at certain times and have certain hours to use the restroom. And, try to limit her amount of, or restrict her amount of fluids during the day. Try to decrease things that she would make her diurese a little bit more, like coffee, alcohol, things like that is what I would suggest at first.
Okay. All right. Yeah. And the other thing is to avoid bladder irritants. Like, so, there are different things like acidic beverages, caffeine, artificial sweeteners, alcohol, all of those can irritate the bladder and make voiding more frequent. And just so you guys know, that is fine. If your practice is we don't take care, our job is to diagnose the incontinence and prove it's not a UTI. And if it's anything more than that, we send them off to the specialist. And that's how you practice, and that's fine. But it would be good to know, well, once they go to the specialist, what do you think they're going to do? And in somebody like this, it would be, like you say, the time voiding, the avoiding the bladder irritants. We've actually found if they're overweight, we can talk to them that weight loss can help with urge incontinence. What if she was 58 and estrogen deficient? Does vaginal estrogen help with urge incontinence?
I'm sorry, repeat the question, please.
Does vaginal estrogen help with urge incontinence in somebody with vulvovaginal atrophy?
I'm not sure, but taking a wild guess, I don't think it would help. In my mind, I'm thinking that it's, it's that there's these sporadic contractions of the bladder and the detrusor muscle that, that just make her use the restroom. So I don't think that estrogen cream would help, but I would have to look it up for you.
It might. So there are some studies that show that women who are postmenopausal and estrogen deficient have more urgency and frequency. Does it actually help the incontinence component? Not exactly sure, but vaginal estrogen is a reasonable option to try.
Okay.
Okay. All right, good. All right, any questions for me?
Not off of the top of my head at this point.
Okay, great. Good job. Thanks.
Yep.
All right, so let me see if anybody else. Oh, sorry. Okay, so now anybody, how about anybody who's only been called down one time in September? And you've only been called down one previous time and you would like to go. Hey, Anzi.
Hello.
Hey, how are you doing?
I'm okay. How are you?
I'm doing just fine. Let me find you here. All right, you're a subspecialist, right?
Yes.
Yeah, I thought so. I remember when I called on you last time. GYN onc?
Yes.
Okay, all right. See, I have a good memory.
You do.
Well, maybe it's because your name's a little bit unusual. That makes it a little bit easier to remember. All right, do you have a preference?
I would say let's try maybe office practice since
All right.
I see you're very knowledgeable and I would love to hear what you can ask.
All right, let's just see here. Let me try to find something that's maybe not so cancer related, something that I
Yes.
can do here. Let's do patient number 25. Okay. So you have a 38-year-old. So I'm not quite sure what you're telling me here. She had PID. She was already hospitalized?
Yes, she was treated previously for a PID and I guess she came for a follow-up with me.
Okay, all right. So let me kind of turn it a little bit different. I'm going to say, what would you do if this patient came in to see you, 38 years of age, G5P1 with the complaints of like some lower abdominal cramping pain, increased vaginal discharge. She does tell you that she's in a new relationship. You do an exam, you see some increased vaginal discharge, cervical motion tenderness, and uterine tenderness. What's your diagnosis?
Okay, I would first get a good history from her in terms of if she's ever had pain or symptoms similar to this. If she has any history of sexually transmitted infections previously, if she's sexually active with men, women, or both, and how many new partners she's had recently in the last 6 months. I would also ask her about her use of condoms with her partner or unprotected intercourse, and also if she has any anal intercourse or oral sex as well. And I would want to know if she's having any fevers or if she has any history of endometriosis. I would also want to think about non-gynecologic issues of her pain, although with these symptoms I would be more concerned about gynecologic issues. So I would specifically want to know any Crohn's or ulcerative colitis issues in her history.
Okay. All right. So let's say she comes in and says, no, this has been going on for about the past 10 days. It's just getting progressively more cramping. I'm noticing more discharge. It hurts to have intercourse. And the exam is as I told you. She doesn't have an acute abdomen, but she does have cervical motion tenderness, uterine tenderness, some vaginal discharge, and her cervix, it looks like there's a cervicitis going on. What is her diagnosis based off of what I just told you?
Based on this, it is pelvic inflammatory disease. I think
Okay.
that is a clinical diagnosis based on those findings.
Okay. So tell me when you feel you would hospitalize somebody for PID.
Pregnancy would be one, so I would want to make sure I check for a pregnancy test. Also, anybody who's immune suppressed, whether that's HIV or other immunologic condition, or maybe being on chronic high dose steroids. Anybody with history of cancer on treatment. Also, somebody who's got a fever, a high fever, or concern, high fever, tachycardia, and hemodynamically unstable. If she has evidence of SIRS, so elevated respirations, heart rate, elevated white count, those are all things I would consider. Also, if on pelvic ultrasound we found that she has tubal ovarian abscess, those would be kind of reasons for considering inpatient treatment.
Okay, so let's say in this case, you even did an ultrasound, no evidence of a TOA, her pregnancy test is negative, she's able to tolerate PO, and you make the decision that you're going to treat her as an outpatient. What antibiotics are you going to put her on?
I would give her, so it's cefoxitin, I think it's cefoxitin, 500 milligrams, I'm remembering this correctly, and times 1, and 1 gram of azithromycin, and then consider also treating her empirically with flagyl 500 milligrams POBID for 7 days. And
okay, go ahead.
And doxycycline for 7 days as well, 100 milligrams POBID.
So cefoxitin 500, azithromycin, flagyl, and doxy.
Yes.
Okay, so tell me when you're going to see her back. So you're going to start her on medical therapy. When are you going to see her back to see if she's improving?
Yeah, I would usually do a short-term follow-up. I would give her instructions that if she develops worsening while on treatment, to have evaluated at the urgent care, the emergency room. But otherwise, I would like to see her back in a week or less.
Okay. All right, let me put that less under. Okay, now you also talked to her about the risks of PID. What are those risks?
So risks would be, again, divided into sort of long-term and short-term sequelae. Short-term sequelae could be sort of need for surgery if there isn't resolution, or if she develops a tubo-ovarian abscess, possible hospitalization. Let's see.
What about long-term?
Chronic pelvic pain, infertility due to a tubal factor. Those are the top ones that I can think of right now.
Okay, so let's say in the cervical swab, the vaginitis swab, it actually did come back positive for chlamydia. So you're going to talk to her about STIs. It looks like you already did. Anytime somebody gets a positive STI, we're supposed to also do the serologic testing, which you did. How are you going to counsel her about this positive chlamydia test? Yeah, I guess I'm gonna leave it at that. How are you going to counsel her about the positive chlamydia test?
I would counsel her, again, in terms of the treatment, but then also the consequences on potential fertility. So one is getting her treated, but also potentially expedited partner treatment to let her partner know about this positive test and offer treatment.
Okay, if she was 38, came in with just a new sexual partner and said she wanted to be tested for STI, she has no symptoms whatsoever. Her chlamydia comes back positive. So now you're just treating an asymptomatic chlamydia. Do you know how you would treat that?
I would, an asymptomatic chlamydia, you could treat with azithromycin, 1 gram one time, or you can do, I believe, a lower dose over a week, like 500 and then 200, something like this.
And what would you actually offer her partner for expedited therapy if you're able to do it?
I think it's a one-time PO dose of 1 gram azithromycin.
Okay, and when are you going to see this patient back and retest her?
So retesting or test of cure, I'm thinking, I mean, I would want to see her for follow-up sooner, but I think test of cure is a month later potentially, or something like that. I don't remember the exact length, but it's at least 3 weeks. I know it takes some time for the PCR to be negative because it is an intracellular organism.
Okay, all right. So good. I think I'm going to stop there, and I'm glad that we did this because this is not something that you do.
No.
Hardly ever. So as a GYN oncologist, you're like, I don't have 18-year-olds coming in to tell me they just had sex and that they've got something going on. So anyway, a lot of what you gave me was the quote old antibiotic doses, because in August of last year, the CDC updated their new STI treatment guidelines. So I'm really glad that we did this. So let's just talk about chlamydia, the asymptomatic chlamydia, that we're supposed to be screening all patients, 25 or less at their annual exams. Anybody who requests it, anybody who has a new partner, etc., we should screen for GC chlamydia. If the chlamydia comes back positive, used to be 1 gram azithromycin is what we recommended for her and him. No sex for at least 7 days after the last person was treated, okay? Now they say for women, we get better eradication if we use 100 milligrams of doxycycline twice a day for 7 days for chlamydia. The guys can still take 1 gram of azithromycin. Now, Who should you not give doxycycline to? The
Pregnant.
the pregnant woman, the person who tells you they're allergic to doxycycline, or if you really doubt they're going to be compliant. If you have a 17-year-old and 17, 18-year-old, and you're like, there's no way she's going to complete this course of doxycycline, then it's reasonable to give her a dose of azithromycin, but knowing that the doxycycline is what's preferred. All right. As for test of cure, we only do that in pregnancy. And we do have to wait 3 to 4 weeks because it takes that long for the gnats not to be a false positive. You are right. So we only do test of cures in pregnancy. We do test for reinfection in our non-pregnant patients. So we see them back in 3 months and retest them.
Okay.
Okay, PID. The treatment for PID is actually ceftriaxone or Rocephin, not inpatient is cefoxitin, but outpatient you're going to give them a IM injection of Rocephin or ceftriaxone, and the new dose is 500 milligrams. It used to be 250, so you're going to give them 500 of ceftriaxone plus 100 milligrams of doxycycline twice a day for 14 days, and metronidazole 500 milligrams twice a day for 14 days. Used to be, we said, you can add Flagyl or you don't have to add Flagyl. They're now say, oh no, do it. And there was a really good study that showed an improvement of persistent pelvic pain when the outpatient PIDers took all 3 of those. So she wouldn't get azithromycin at all. She would get the 500 Rocephin, doxy for 14 days, Flagyl for 14 days. Okay, and that's just part. And the only reason I kind of really wanted to go over that is because it is new guidelines from August of, well, a year ago, 2021, and I could see them asking you about that. With just gonorrhea, you give them the 500 of ceftriaxone. You don't do dual therapy anymore, unless for some reason you really didn't test for chlamydia, but we test all. I mean, when we get the GC, you get both. And it's weight based. If the patient weighs more than 150 kilograms, they say give a gram.
Okay.
But everything else you said was spot on of when you would admit, if they're pregnant, if they're unstable, if they have a TOA. The other thing is if they fail outpatient therapy. So if you saw her back in 3 days or even 7 days, that'd be the most I would push it. But if you gave them good instructions like, hey, if you're not feeling better, I need to see you sooner. And then the only other one is if somebody had an acute abdomen kind of, and you weren't sure, was this appendicitis? What is it? Let me try to think anything else. Other than that, the bar to diagnose PID is really low because the consequences to not treating it are so significant. So, CDC says any sexually active patient who presents with lower abdominal pain, and you've ruled out any other etiology, and they have just any one of the following: cervical motion tenderness, uterine tenderness, or adnexal tenderness, that's enough to make the diagnosis of PID, and you should start treatment. And there are other things help to confirm your diagnosis, but aren't necessary to make the diagnosis or start treatment. Got it?
Perfect. Thank you so much.
Okay, thanks. Nope, it was a good review for everybody. All right, so let me see any other hands. Oops, wait. Melissa. Hey, Melissa.
Hi.
Hey, how you doing?
Great. How are you?
I'm doing good. Let me see, find you. Do you have you're a generalist, right?
Yes.
I thought so. Where are you? Cures.
Keep going lower. There.
Oh, there you are. Okay. All right. So do you have a particular case or case list? Hello? Uh-oh. How come I can't hear anybody? Melissa? Can you hear me? Attendee is muted by the organizer. Can you hear me?
Okay. Yes, now.
Okay. Oh, phew. I was like,
Yeah.
where'd she go? I was like
Yeah.
panicking.
Yeah, it
Okay.
froze or something. I can
Yeah.
hear you now.
Okay, good. So do you have a particular case or case list?
Nope. I want you to just pick for me, please.
All right. We haven't done any OB, have we? When do you test, Melissa?
October 18th.
Okay, so you're coming up. So let's look at patient 93. This was your 25-year-old G2P1. She had a history of a third trimester IUFD. She's GDMA2 and has class 3 obesity. So when she comes in with her class 3 obesity, how did you counsel her about her risks of obesity in pregnancy?
So, of course, by the time she had seen me, she had already, although there's a bit of first trimester loss, she was already basically close to having. I do counsel her on her risks as far as gestational diabetes, her risk of a third trimester loss, she has her has risks as far as specific congenital anomalies, such as potential for heart defects, neural tube defects, cleft lip, cleft palate. It can be also harder to diagnose congenital anomalies in these patients. I start with some of those as far as counseling is concerned with obesity.
Oh, okay. Can you hear me? It seems like we keep kind of going in and out.
Yes, I can.
Okay, good. All right. So anyway, so you talked to her that she's at increased risk for gestational diabetes, a third trimester loss, congenital anomalies of which you've listed nicely, and that it will be harder to diagnose those anomalies based off of due to her body habitus. If you had seen her at her new OB visit, are there any baseline labs you would get on her that would be different than just a normal new OB visit?
Besides her normal new OB visit, I would also get an early 1 hour glucose testing on her.
Okay. What are you going to counsel her about appropriate weight gain?
So in as far as weight gain for her, I would talk about as far as, you know, I'm really I discussed weight gain in pregnancy as kind of a paradox, and that with her obesity level, I would really only want her to be gaining approximately like 10 to 15 pounds throughout her entire pregnancy.
Okay.
So we discuss as far as weight management and discuss as far as like calorie intake.
Okay. So with her gestational diabetes, what pharmacologic agent was she on and why?
So this patient in our practice, typically with gestational diabetes, they per my practice guidelines, they will tend to um, put it is a toss. So they are sometimes co-managed by endocrinology, and sometimes they are managed by the OBs themselves. This patient, although insulin was what was recommended for her, the patient was fairly was declining insulin treatment and was attempting to, so they were doing management with her with glyburide.
Okay, why not metformin?
That was the endocrinologist's choice. If when I am more when the patients are being solely managed by myself, I tend to go with insulin as a choice first, as far as if we are unable to control with diet choices. But this was an
Okay.
endocrinologist.
So tell me, why insulin? Why do you prefer insulin?
With insulin, there's overall better control, as well as a little bit more fine tuning as far as, insulin resistance increases throughout pregnancy, and I'm able to adjust dosaging a little bit more specifically, and just more effective overall glucose control.
Okay. All right. So now, so she's a GDMA2. She's on glyburide per the endocrinologist. You said you're doing serial growth scans. Tell me when you started those and why you're doing them.
I started serial growth scans on her well, the first reason I started her serial growth scan was due to her previous third trimester loss. And I start that at about at 32 weeks. And then it was also right around the 32, 33 week time frame as well, when her diabetes was felt to be not diet controlled. So typically for somebody who I have on medication, like insulin treatment for diabetes, I will also obtain growth scans every 3 to 4 weeks, starting around 32 weeks as well.
Okay, so tell me why you chose to induce her at 37 and 3.
So the decision for that had to do with her previous loss was at 38 and 4. And it was a macrosomic baby. The baby was just under 10 pounds. I believe there was, in the notes, it looks as though there was also a shoulder dystocia with that demise. The baby had already passed, but the patient had significant anxiety regarding her previous loss, which was less than 2 years prior to this, as well as being her with her diabetic control, as well, being slightly less adequate as far as, her postprandials were still slightly outside, or more 130s to 150s. So a combination of where her diabetes control was at, as well as the patient's anxiety from her previous loss, we discussed delivery at a slightly earlier time frame.
Makes sense to me. The fact that that previous IUFD also was macrosomic, as you said, and had a shoulder dystocia. Did you discuss with her options for delivery? Like, did you ever consider just offering her a cesarean based off of that previous shoulder dystocia?
So although that may have been discussed at an earlier visit, all her growths for this pregnancy were noted to be AGA, and not noted to be like hitting, and even like wasn't even hitting close to the 4,000 gram mark. The risk of a repeat shoulder, the risk of a possible repeat incidence of a shoulder dystocia was discussed with her. However, since we had agreed upon a delivery prior to 39 weeks, with the discussion was had, and she was comfortable with proceeding with a vaginal delivery, given that this was a 37-week delivery and not an 39 or 40-week delivery.
Okay, awesome. All right, good. All right, so good job. So a couple of different things. Number one is when we you did a nice job on the risks, but whenever a nice way to organize your thoughts, and this is for everyone, Melissa, if they ask you, so what's the risk of chronic hypertension in pregnancy? What's the risk of smoking in pregnancy? What's the risk of obesity in pregnancy? When there's so many different risks, it gets really confusing. Did I say this? Did I say that? Try to outline it. Say, I think of it in terms of maternal risks and fetal risks. And then you can go back to the maternal risks. And you talked about gestational diabetes. That's probably the main thing you talked about with that. The rest of it would be fetal, the third trimester loss, the congenital anomalies, harder to diagnose. But now that I broke it down into that, can you think of any other maternal risks of class 3 obesity?
Yes, chance of prolonged labor, higher risk of C-section, higher risk of postpartum hemorrhage.
Yeah, good. So she's at increased risk for labor dysfunction, cesarean delivery, a wound infection, healing because of her obesity. If she gets a C-section, she's increased risk for preeclampsia, which is why the obesity is one of the minor things. DVT risk,
right,
for sure. And then we're supposed to also screen these people for obstructive sleep apnea. So there's a big long list for that. And then with the fetus, so we're talking about really loss in any trimester, but increased risk of IUFD third trimester, the congenital anomalies, harder to diagnose. What about growth? What about growth in somebody who's obese for the baby?
They could possibly be at risk for macrosomic infant.
They can actually be either. It's like too big or too small. It's odd.
Yeah.
Yeah.
Okay.
So that's why, and because we can't adequately assess fundal height in most of these patients, we have to do the growth ultrasounds. All right. Then with regards to the agent to use for gestational diabetes, absolutely insulin gives us much tighter control. We're going to get, which is preferable. But the big thing is insulin does not cross the placenta. It's a really large molecule. So we're normalizing the mom's blood glucose, and all that baby is seeing is normal blood glucose. Whereas with glyburide or metformin, they do cross the placenta, and we truly don't know long term if that could have some kind of an effect. And if a patient refused insulin, per ACOG, the recommendation would be to go with metformin. So what do you do, Melissa, when you have somebody else managing them and they're not doing it the way you would? So if they said to you, so what was this patient on insulin? You could say this patient was actually on glyburide, and that was per the endocrinologist. And you can take control of situations like this. You could say, had I been the one managing her, this is my recommendation and why. And that's for anything. All of you guys will have patients who you did not even do her antenatal care. You just happened to be the one on the day of induction, or she came in labor, whatever. And you may not have managed her the way that was done. So you could just say the antenatal care was actually performed by one of my partners or one of my colleagues. If I had managed her, I would have done it this way, but this was the way it was done. Does that make sense? And you're not throwing anybody under the bus.
Yes, I'm actually probably just gonna say that sentence back to you just because I do have a little bit of anxiety about like how it looks as far as like, well, why didn't you just manage her? And like that's just not always how it works in my practice. For like sometimes one of the other providers, for example, will just send the referral to endocrinology. So if I could just say, you know, this patient, her gestational diabetes happened to have been managed by an endocrinologist, and they had chosen glyburide as an agent. Had it been controlled, this been managed by myself, my first choice is insulin management, and just leave it at that.
Correct, 100%, that's correct. And same
Okay.
thing is, you know, that's who did it. And with regards to, like I said, for any different things, you can say, I did not, um, my my portion of the care for this patient was her labor and delivery. Her antenatal care was by my partner, you know what I mean, or whatever. But if I had managed her, I would have done X, Y, and Z. And so, and they know that. I don't think I have anybody who's a solo OB practitioner who everybody does that. So that's common and they expect that. All right. So that was a good thing to go over for everybody. So thank you for that.
Great.
All right,
Thank you very much.
I think we can get one more last one in because time flies when we're having fun. Let me just see here. Let's see if there's any other names I see here that haven't been. All right, Dr. Joseph, let's get you in here.
Hello?
Hey, how you doing?
I'm good. How are you?
I'm good. Let's find you. All right. What case list or case would you like to do?
We can do office or OB.
Okay. Or maybe let's do another quick OB one because we haven't really done too much. Go. Let's look at patient 20, 32-year-old G3P2. She had cholestasis in a previous pregnancy. So if you have cholestasis in a previous pregnancy, well, do you know even what's the likelihood that it can recur in a subsequent pregnancy?
The recurrence risk in a subsequent pregnancy can be as high as 90%.
Yeah, it can be super high. Do you know of any medications that, like, if somebody's not pregnant, are there any medications that you might possibly prescribe to someone that could actually cause a cholestasis type presentation?
I would think that if a patient, like all contraceptive medications can affect liver function, so maybe that.
100%. You're one of the few people who knew that. Yeah, estrogen containing OCPs in patients who have a history of cholestasis, it can actually trigger the same, you know, bile acid stasis, etc. With the hormones in it. Does not mean it is not a contraindication to give somebody who had a history of cholestasis to put them on an estrogen containing OCP, but just be aware that if they would start feeling that itching and stuff, think about that. Oh, you know what? Maybe we need to go to a progestin-only contraceptive. All right, so prior history, she had cholestasis. Tell me how she presented and how you made that diagnosis of cholestasis in this pregnancy.
So for this pregnancy, the patient had reported itching, and given her history, I was prompted to do an elevated, like a bile acid study on her, which was elevated. And so that's how I made the diagnosis.
Okay, and so itching. So she comes in itching. Tell me what are some things that are classic for cholestasis and like how is it different than PUPS? Let's start with that. How would you differentiate cholestasis from PUPS?
So with cholestasis of pregnancy, they typically have the itching of the palms and the soles, but no rash. Whereas with PUPS, you can see a rash. And other presentations for cholestasis, the patient may report dark urine and pale stools.
Okay. And then PUPS. What's the significance of PUPS? What would you do with that? How would you monitor mom, baby, etc.?
For PUPS, the significance is that you'd have that you can that the you can it's not that you're not at increased risk for adverse outcomes compared to cholestasis, but that the patient's symptoms can be managed more conservatively.
Okay, what would you recommend for pups? The itching, the rash primarily in the stria of the abdomen.
The patient could try oatmeal baths. They can also try topical um, tar preparations.
Okay, all right, so now let's go back to cholestasis. This patient comes in, she doesn't have a rash, she's had it in a previous pregnancy. She says, this is the same itching I had from before. You send off labs, it's gonna take a while for those labs to come back. Tell me what you're gonna do in the meantime.
In the meantime, given her history, I started on ursodiol because the thought was that it's likely cholestasis again, and told her that we reviewed the risk of stillbirth with cholestasis of pregnancy and started the patient on antepartum fetal surveillance.
Okay, and so what's the significance of a bile acid greater than 100?
With a bile acid greater than 100, the patient is at a higher risk of having a stillbirth.
Okay, and so in when would you want her delivered if she had that high of a bile acid?
So ideally, with that high of a bile acid, you could consider delivery between 36 to 37 weeks.
Okay, all right, and then we make the diagnosis when what's the minimum amount that bile acid should be elevated in order to quote make the diagnosis?
It depends on the lab, but my cutoff was 10 micromoles per liter.
Okay, all right. And so this case, she had cholestasis, you did the surveillance, she's on your sodiol, you did induction of labor, and she had an SVD. Trying to think if there's anything else I could ask about this. Do you know why do women get cholestasis in pregnancy?
They get cholestasis because you have a blockage of bile acid transport from the liver to the gallbladder, and so the bile acids then get into the bloodstream, and that causes the itching.
Okay, that was excellent. You know your cholestasis, don't you? No, seriously, that was excellent. And do we know why? Why do elevated bile acids? Why does it cause increased risk of IUFD?
It can cause increased risk of IUFD because it also affects, it can go into the placenta and causes vasospasm of the placental vessels.
And does it get into I know it goes in the placenta. What about into the fetus? Do
It
bile
can,
acids?
because it can cause like fetal arrhythmia and heart block in the fetus.
Yep, that's exact. Yeah, and because I know they still don't know exactly, but the theory is with the bile acids crossing the placenta, because here's the problem. Normally, if you do a non-stress test on someone and it's reactive, do you know what we're supposed to be able to tell the patient about the likelihood they could have a IUFD in the next 7 days if they have a reactive non-stress test? Do you know what we're supposed to tell them?
That I know that it's likely, like, if the positive predictive value is like 10%. I'm not quite sure.
Yeah, I'm not sure how I would say that, but I know
Yeah.
it's something like 1 in 1,000. The
Yeah, okay.
likelihood that this baby you would have a demise in the next week if you have a reactive non-stress test is like 1 in 1,000. So that's why it's so reassuring. But with cholestasis, those antenatal testings do not predict fetal loss, do they? It's not like with our
No.
growth restriction that you can have a normal NST the day before and then have an IUFD, which is why they use levels of the bile acids to almost like assess risk, and that's why the greater than 100 will oftentimes be at 36 weeks. So it causes some sort of an acute event, and one of the theories is exactly what you said. The bile acids concentrate in the fetus, and it may cause some sort of a lethal arrhythmia or something like that, because it's causing something acute. It's not like it's uteroplacental insufficiency and just a gradual, poor perfusion, etc. So yeah, it's weird. But excellent. I have no other questions. Do you have any questions for me?
I do. Can we review pubs? Because that kind of caught me off guard. I'm
Okay.
a Eurogyne fellow, so
Okay. So
this,
anyway, so PUPS is that they're trying to call it something different now, and I wish I could remember what it is, but that's the old pruritic papules of pregnancy. And what it is that they get little red bumps, and it's primarily on their abdomen, and oftentimes it's in the stria. They actually think it's almost an allergic reaction to collagen exposure, like the stretching of the skin causes exposure of the collagen that normally would be intradermal, and it causes almost like a urticarial type reaction. So the mom will itch, itch, itch. And so she comes in, it'll be on her abdomen. It does not cause any adverse impact to the baby. It doesn't cause any adverse impact to the mom, except it drives her nuts because she's itching. You basically treat her symptoms. You can do oatmeal baths, you can do topical steroids. If she was really itching like crazy, you can give her Benadryl or something like that. But it's just, yeah, one of those, it's just a rash that generally occurs in the 3rd trimester. And that's the theory, that it may have something to do with collagen.
Thank you.
Okay, all right, thanks so much. Let me see if I can find where you are so I can mute you out. Oh, well, I can't there. All right, guys, it's a little bit after 10. I'm going to call it here, and I will be back with you guys next month. Thanks so much for participating.